This is Dr. Wei Ling Wong, and this is my seminar presentation for the subject Bioethics in Healthcare. The topic of my presentation is euthanasia in a dying adolescent. My presentation will give you an overview of the special considerations that need to be taken into account when a dying adolescent makes the decision to die, the issue with determining autonomy and decision-making capacity in this unique group of patients, the debate around pediatric euthanasia, and I'll be wrapping up the presentation with my thoughts on the topic. Now, several psychologists as well as pediatric clinicians suggest that dying children can actually reach an understanding of their impending death as the cumulative result of their own experience with serious illness and medical treatment. Now, with this concept of graduated understanding of death, it is generally considered that through their exposure to death as part of life, that all adolescents should achieve an adult awareness of death as something that's universal, unchangeable, and permanent. Hence, care providers for children and adolescents concur that by the age of 14 or 15, most adolescents can understand the meaning of death. This graduated ability to understand death and their illnesses suggests that adolescents may have the functional competence to make decisions about their healthcare. Now, the legal debate is fairly straightforward. In most Western country states, patients above the age of 18 are empowered to make decisions for themselves. However, it is noted that the law do permit adolescents under the age of 18 to make certain medical decisions which they would otherwise leave untended if their parents are notified and involved, such as pregnancy, sexually transmitted illnesses, or drugs. When it comes to pediatric patients and adolescents, parents are entitled to decide what medical treatments their child will or will not have. There is debate on how best interests for a child is actually conceptualized and determined, and if parents alone know what is best for the child. It should also be noted that this entitlement is subjected to court intervention if the parent's decisions seem not to be in the child's best interest. In supporting the autonomy of minors and caring for the adolescent, it's important for carers to recognize how influential their professional roles may be. For the dying adolescent, an appropriate approach to enhance autonomy is one that goes beyond merely providing factual information, but also to assist him or her in recognizing key personal values. Now, on the topic of euthanasia and legislated pediatric euthanasia. Euthanasia was legalized in Australia and Northern Territory in 1995, but this was later voided just 2 years after it was implemented. Physician-assisted suicide is also permissible in 4 American states. Now, Netherlands and Belgium passed the laws to legalize euthanasia in 2002. Now, what is unique to the Dutch and Belgian law on euthanasia is that it extends to the pediatric population as well. In the Dutch law, euthanasia and assisted suicide are allowed to minors after the age of 12. In 2014, the Belgian law extended euthanasia to all minors irrespective of age, and this sparked multiple ethical debates. For those who support pediatric euthanasia, it is suggested it is reasonable to assume that much of the motivation behind the euthanasia movement and the performance of it is a genuine, compassionate desire to alleviate pain and suffering. Statements by the Royal Dutch Medical Association and Dutch Pediatric Society actually indicates that pediatric euthanasia was already practiced in Netherlands on children and newborns and adolescents prior to the passing of the legislation decriminalizing euthanasia. Supporters argue that the slippery slopes in decision to cease treatment may be more risky, as decisions of active euthanasia are more carefully studied than decisions to withdraw aggressive treatment. Now, we know this in part because reporting rates have dramatically increased in Netherlands with the legalization of euthanasia from 18% in 1990 to 80.2% in 2005. With this significant amount of data, decisions can be made with more precision than they could be if there was not such constant attention paid. When proposing and planning various treatments for pediatric patients, emphasis on patient self-determination as an ethical value that maximizes this patient's participation in decision-making process. In this context, decisional capacity and voluntariness should be viewed as a developmental and individual process and evaluated on a continuum with many other pediatric patients, especially older children and adolescents, possessing these characteristics to some degree. This is supported by a study which demonstrates that children aged approximately 7 are usually capable of assenting to treatment, and adolescents aged approximately 14 can usually give voluntary consent to treatment. A Belgium study investigating the attitudes of adolescent cancer survivors towards end-of-life decisions demonstrate a desire amongst this group of adolescents to be involved in their medical decision-making at the end of life. These adolescents also value autonomous decision-making without excluding their parents from the process. This study has also supported the notion that experience of living through life-threatening illnesses can actually alter adolescents' attitude towards requests for non-treatment decision and alleviation of pain symptoms. Objections to pediatric euthanasia argue that palliative care is preferable and better aligns with the traditional healing goals of medicine. In this regard, Hansen in his paper proposed that euthanasia should be considered as an effort to heal when cure is impossible. When making difficult decisions for children and adolescents, the American Academy of Pediatrics and Laws advocate making the treatment decisions that are guided primarily by the best interests of the child. Now, this leads to arguments from supporters of pediatric euthanasia on whether euthanasia can ever be in the best interests of a pediatric patient, and whether the parents and physicians of the child are capable of making such a judgment. Parental assessments of the best interests of a child is often only an assessment of what the parents themselves know would be unbearable suffering. It is inherently shaped by the process of what information is given to them. Hence, supporters suggest that guidance should be sought from the worldview of the patient through informed consent, as the rationale for doing so is that only the patient can know which of her treatment alternatives will best promote her best interests as interpreted by herself. The argument that palliative care is and should be an important part of end-of-life care for any patient is recognized as a valid point, with Belgium's move to pass a second act to double the funding for palliative care in hospitals, nursing homes, and at home. This provision of active euthanasia has not found to entail poor palliative care in Belgium, and in fact, Belgium ranked third in the world for their quality of palliative care. For those who are against pediatric euthanasia, it is argued that there is no actual demand for the extension of the law. This came as an open letter from around 170 medical practitioners to the Belgian Parliament, arguing that the spontaneous and deliberate requests for euthanasia are extremely rare on the parts of minors, and in those cases, their pain can be fully relieved through palliative care. Now, this notion was supported by Marie Fredel, a pediatric nurse who summarized the main positions of those who tried to oppose the new law. Citing the European Association for Palliative Care, that the degree of medical specialization in palliative care might be lower in countries where euthanasia is legalized. On the point of the real capacity of discernment in minors in choosing euthanasia and understanding the consequences of such a choice, non-supporters of pediatric euthanasia quoted the Australian law that does not admit self-determination in children, grounding its approach on modern neuropsychological studies that demonstrate how this capacity of decision-making is not fully developed until around the 20s. Authors also expressed serious doubts about the ability of self-determination in children. The authors pointed out that the preference of dying over living an undignified condition requires a very complex and sophisticated form of judgment, which is beyond the intellectual ability of many children. Hence, the reasonable doubt about the inability to gauge the competence of a child in life and death decisions should refute the law. The legitimacy of euthanasia has also been questioned, with objections that mere consent between two subjects does not grant the moral value of inaction. Non-supporters also discuss the unavoidable conflict of medical duties to relieve suffering and the duty to protect or respect life in the real clinical situation. It is suggested that this conflict will be put to an unacceptable or unmanageable level if one considers termination of life as an acceptable means to end suffering. It is argued that to decide which life is not worth living for includes a discrimination inconsistent with the physician's duty and with the values of a just democratic society. Non-supporters also presented the slippery slope argument, which holds that the euthanasia weakens the society's perception of the value of human life and opens doors to all forms of social discrimination, and it is the role of societal norms to present as barriers against such judgments. There are worries of a cultural effect that slowly leads the society to a passive acceptance of the new practices that are inconsistent with the societal organization and may bring dissolution to the society itself. It is believed that the acceptance of the euthanasia for children demonstrates exactly this erosion of the social reserve to euthanasia and a progressive acceptance of this practice as a medical intervention. Now, I think the debate on pediatric euthanasia is heavily focused on patients' capacity, autonomy, and their rights to make end-of-life decisions. Supporters tend to argue this point really well, with the recognition that children progress in age and life experience, and they develop the ability to reason and understand. The notion that adolescents who are mature in their thought processes through experience in life and death, their illnesses, and their medical journey, desire and are capable of autonomous decision-making is supported by law through the mature minor doctrine and some studies. I think that non-supporters do not argue this point really well, as they often make the blanket statement that it is just too hard to ascertain capacity for medical decision-making in children and adolescents, without acknowledging that adolescents have increasing ability to do so through their life experience. It should not be a surprise to anyone that the two sides have different opinions on the slippery slope argument. Supporters maintaining that the legalization of pediatric euthanasia will not lead to the abuse of the practice due to the availability of strict governance processes. Now, non-supporters deem that the decriminalization of pediatric euthanasia will lead to erosion of the society's reserve to protect what's deemed as common goods and the propagation of the practice as a routine intervention. While I am in the opinion that the rights to be reserved from suffering should not be determined by age, I support that the individualized evaluation of functional capacity to comprehend life and death, quality of life, and the consequences of end-of-life decisions in adolescents against their circumstances and life values is vital, very vital to protect the vulnerable. I think it is also crucial to respect and recognize that adolescents with comparably more life experience and enhanced intellectual capacity, especially those with chronic diseases or terminal diseases compared to young children, has the ability to make decisions about their healthcare. I personally think that it is important to adopt a holistic approach to facilitate the acquisition of maximal autonomy and decision-making competence, and this involves open, honest, age-appropriate communication, graduated involvement of medical choices to prepare the adolescent and their family for the crisis of terminal illness and its array of associated decisions, and providing psychological and social support that can be provided through psychiatrists, psychologists, social work, and religious leaders. That wraps up my presentation. Now I'll leave you with this question to think about and stimulate discussion.